All right, so this is the second part of Study Guide 2. I think we have 3 cases. First is another headache case. So this time we've got a young woman. She has polycystic ovarian syndrome and she is on oral contraceptives. So that's kind of an important thing sometimes to note, especially when you're concerned about clotting. She presents to the emergency department with a pounding headache for the past 2 days, and it's getting worse. Doesn't sound like there's any kind of pertinent history here. She has photophobia. She has no photophobia or phonophobia, no nausea, no vomiting, no neurologic changes. So that's reassuring. But she does feel like her vision is blurry. So that's kind of a neurologic change there. And when you look in her eyes with the ophthalmoscope, you note an abnormality that we'll see in a moment. But otherwise, her neurologic exam is normal. So what you see when you look in her eye is, let's say you see this. So this is papilledema. All of these are papilledema. That's papilledema. But I just wanted to show you a range of what it could look like. And the main thing is that you just don't have these sharp disc margins and these venous pulsations. So if you see any of this, that is alarming because it could be an indicator of raised intracranial pressures. And I know that many of us are not very confident unless we're going into ophthalmology in our exam, our eye exam, to be able to diagnose papilledema. And that's okay. It can be really challenging, especially in the emergency department in a patient whose eyes aren't dilated. But if you hear that a patient has papilledema and you hear it on a good source, you have to take that seriously because that is an indicator of high ICPs. So you order a stat head CT, very reasonable plan. Come up with 5 possibilities on the diagnosis for me. So pause the video, get your pen, get your paper, and write down 5 diagnostic possibilities. Here's what I wrote down. And first and foremost, I'm worried about a dural venous sinus thrombosis, which turns out is what it is. And we'll talk more about that in a moment. My second one I realize is kind of stupid. I wrote idiopathic intracranial hypertension, but that's kind of more a chronic process. And she's got more of an acute presentation. So what about a rapidly growing brain tumor? CNS infection, we've been down that road before. It'd be rare for a young woman to have an intracranial hemorrhage, but that's certainly a possibility too. So here's what we get on our scan, and I'm going to just cut to the chase, but here you see this hyperdensity back here on the left, more so than right, but you get the sense that it's kind of all along this area here. Hyperdensity, maybe blood, but it looks kind of funny, right? It's not well demarcated. And so it turns out what this is a venous sinus thrombosis. So venous sinus thrombosis, you guys remember these deep veins, and you remember how all these deep veins come together at the torcula back here. And so this is a common place here in the back of the head, to see clot. But you can get clot anywhere along here. If you have venous hypercoagulability. So these are veins, and there are certain conditions that make us prone to form clots in our veins. And you guys know those things already, right? That's all those things here. So the inherited coagulopathies like factor V Leiden, prothrombin, but also things like dehydration, pregnancy. So pregnancy is a procoagulable state, malignancy. So you know all of this already. It can hemorrhage. So this indeed is hemorrhage back here. So it's a combination of hemorrhage and clot. Clot in the veins is what we're seeing there. But you can also, besides getting hemorrhage, you can also get ischemic stroke. It just looks really weird because it's not in an arterial distribution. If the clot isn't treated, it can propagate, and you can get clot going all the way down to the jugulars, and you can get increasing pressures up here. And so the way we treat it is by anticoagulation, and that's pretty nerve-wracking if there's already blood in the head and you have to anticoagulate. The way we do that is by starting a heparin infusion, and so that way, the effects are short-acting. And so if we need to, if there's bleeding, new bleeding, we can turn off the heparin infusion. We can give protamine, reverse it. Whereas if we put this patient on something like warfarin, it's going to be much harder to reverse. So usually what we do is we start these patients off in the hospital on something like a heparin infusion and then transition them to something easier if they remain stable. The way to diagnose it, on our CT here, this doesn't make the diagnosis alone. You have to get a venogram. And so what we usually get is something like a CT or an MR venogram, which just looks at the venous phase of the blood vessels, and it can show if there's clot in there. I should just say a quick word. I don't want to confuse you. But if you've been listening to the news, recently there have been, I guess it was a couple of months ago now, there was a report of young women getting venous sinus thrombosis like this after the Johnson & Johnson vaccine. That situation is a little bit different because those patients were actually getting venous sinus thrombosis in the setting of a thrombocytopenia. And so it's managed a little bit differently than what I'm talking about here. So just remember that in case it confuses you. All right, case number 2. We're whipping through these. I think we only have 3 cases. So we've got a young woman, 24. She has been having problems with balance, dizziness, fatigue, been going on for a few months. Already had a medical workup that was benign. So she does tell you that 5 years ago she had a weird episode where her right eye hurt and she had trouble seeing out of it. So your challenge here is to pause the video and come up with at least 3 things that can cause painful vision loss, if you can. Okay, here's what I came up with, but this is not exhaustive. I think we could easily come up with a whole page full of things. But some things to consider: glaucoma, optic neuritis, which it turns out is what our patient has, cavernous sinus thrombosis or fistula, which is what is depicted here. So the cavernous sinus kind of sits back there, and you probably remember it's venous sinus, but also it's got the carotid artery and some cranial nerves going right through there. Bad things can happen. You can get a fistula between the vein and the artery. You can get a thrombosis, and it can give you high pressures that give you painful vision loss and a red inflamed eye. And I mentioned that, the cavernous sinus thrombosis, because you may actually encounter issues with the cavernous sinus this month, and so it's a good reminder to just remember that it exists and that there's a little mnemonic for the anatomy there. And then, giant cell arteritis, what the heck, that's not a very good match for our patient who's only 24 years old. So this is another not very good differential diagnosis I've given you, but something for us to remember. Okay, so optic neuritis. So the optic nerve, cranial nerve 2, is actually part of the central nervous system. I know it's a cranial nerve, but it's part of the central nervous system. And as such, it's myelinated by oligodendrocytes. And so if you have a disease like multiple sclerosis that attacks oligodendrocytes, you can get optic neuritis, and it can affect the optic nerve. And so there's kind of a little bit of an overlap with this optic neuritis. You can have people that get optic neuritis and never get any other problems. You can get people that get optic neuritis and then have other episodes of demyelination and ultimately get diagnosed with something like multiple sclerosis or one of the other demyelinating diseases. So we don't know in her case. Well, in her case we do now know. But at the time we wouldn't have known that she might have MS. That she does have MS, as you'll see. Demyelinating diseases, particularly MS, we think young women, and that's true with optic neuritis as well. And I'm going to let you read the rest of this yourself. Okay, so back to our patient. So her medical exam is fine. As she's walking into the exam room, you notice that she's got a really wide-based gait. So she's kind of standing with her feet apart, and she's kind of holding onto the walls to help steady her. So what could that indicate? She's got some issues with her balance. So it could be a problem in her cerebellum. It could be a vestibular problem. It could be a problem with her proprioception. We'll have to see. So you do your neurologic exam and you notice that she's dysarthric. Her speech is slurred. It's her speech production that's slurred. And then otherwise her cognition looks pretty good. Her language and cognition look good. kind of an abnormality in her eye exam. So you notice that when you shine the light, so you go to check her pupillary reflex, you shine the light in her right eye and neither pupil constricts. But when you shine the light in the left eye, both pupils constrict. So when you swing the flashlight back and forth, the right pupil, so you go back to the right pupil again, the right pupil this time actually dilates. So what's going on? It's confusing. So this is the relative afferent pupillary response. And this can happen whenever you've had enough damage to the optic nerve to cause some degree of scarring. And even after your vision has completely returned to pretty near normal, you may still have this finding because it's very sensitive, or very sensitive. So here we go. So this is what should happen, right? So two things to remember. One is with the pupillary reflex, there's two sides of it, right? There's the afferent side, the efferent side. It's a reflex. The afferent side is mediated by cranial nerve 2, the optic nerve. The efferent side is mediated by cranial nerve 3, the oculomotor nerve, which causes pupillary constriction. We know that. The other thing to remember is that each eye has a direct response and a consensual response to light. So if I shine light in my right eye, there's going to be a direct response that constricts this pupil, but there's also going to be a consensual response over here that constricts this pupil. And then if we swing the flashlight, if we have normal optic nerves, and we swing the flashlight back and forth, this is what we're going to see. We're just going to get constriction. It's not going to change. However, if we have a patient with a right-sided afferent pupillary defect, like our patient, we're going to go to shine the light first in the normal eye, the left eye, and both pupils constrict. Then we shine the light in the right eye, the abnormal eye, and that pupil dilates because it's no longer getting the light input because the optic nerve is scarred. And there's no consensual response either in the left eye. So basically, if we were swinging the flashlight back and forth between the eyes, we would see constriction, dilation, constriction, dilation. Okay, so she has that finding. So otherwise, let's see other highlights of her exam. She's got some abnormalities on her coordination exam. So she's got some dysmetria. So dysmetria means when you are doing something like finger, nose, finger, you can't quite hit your target. So if you're asking me to touch this thing, touch my nose, touch that thing, touch my nose, touch that thing, I might past point. I might push too, or I might go too far, or I might not go far enough. I have dysmetria. My brain can't measure the distance there. I might have an action tremor. As I get closer to my target, I might start to shake. And she has that on her left side. She also has abnormal heel to shin response on the left side, and she can't do these rapid alternating movements very well on her left side, whereas on the right, she's very good at it, right? On the left, she's just struggling. Her gait, again, is wide-based. She can't do the Romberg because when you try to get her to stand with her feet together, she really can't maintain her balance. So you don't even have her close her eyes, right? Because if she can't maintain her balance with her eyes open, she's going to fall with her eyes closed. You try to see if she can tandem walk, walk heel to toe. Can't do that. She just falls to her left side. So left-sided dysmetria, dysarthria, right-sided relative afferent pupillary reflex, left-sided dysmetria, abnormal alternating movements and heel to shin on the left, and then she's falling to the left and has poor balance. So what's your differential diagnosis? Give at least 3 things. And then also write down a quick workup plan. What workup would you like to see done initially? So pause the video and then come back. Okay, so here's my differential. MS. So I'm really concerned that she has MS because it sounds like she had optic neuritis 5 years ago. From her history and indeed on exam, there is clinical evidence of a past injury to her optic nerve. So I'm thinking that she's got a new lesion in her left cerebellum that is accounting for her symptoms. What about neuromyelitis optica, which is always fun to say, NMO. So this is another demyelinating disease, and it can cause optic nerve demyelination. It can also cause demyelination in the spinal cord, and those are the two areas it tends to prefer. It also can cause demyelination in the brain, but usually to a less severe extent than something like MS. So, maybe it could be that, because you can get a lesion in the brain with neuromyelitis optica. And then what about something like a left cerebellar tumor or an infarct? You know, maybe she had a stroke in her left cerebellum, or she's got a tumor back there. And maybe that incident 5 years ago was just a fluke. Here's what I want. I want a workup. And so I want to get an MRI of the brain and the spinal cord. So remember, MS is a disease of the central nervous system, central demyelination. So wherever there are going to be oligodendrocytes, we want to look. And so we want to look at the brain and the spinal cord. So I'm going to get an MRI of her cervical and thoracic spinal cord, knowing that the spinal cord ends down there around L1, L2. But we'll get enough imaging of that on the T-spine image. We're going to give contrast. So you remember one time I told you, or a couple of times I've probably told you, there are 3 circumstances where you're sure you're going to want to give contrast. And one is when you're worried about malignancy, one is when you're worried about infection, and then the other is when you're worried about inflammation. And that's what MS is in these related diseases. We might want a lumbar puncture. We might be able to make her diagnosis without having to do a lumbar puncture, but a lumbar puncture can be helpful when you're working up multiple sclerosis, because you can have findings like increased oligoclonal bands and IgG index, and sometimes this can help you distinguish between MS and other diseases, demyelinating diseases and infectious diseases and whatnot. In her case, we may not need it, and if I can spare a patient a lumbar puncture, I'll do it, but if we need it to clinch the diagnosis, we would do it. And then also another test that she may not necessarily need to make the diagnosis would be visual evoked potentials. And this is just a test that I think I show you in a minute that more objectively assesses the integrity of the optic nerve. Yeah, so here's the visual evoked potentials. This is not our patient here because it's the wrong eye. But if a patient had demyelination or an optic nerve injury in the left eye, this is what you would see. So basically what they do is they strap electrodes on the patient so that they have them in front of a TV screen and they show this checkerboard pattern, and the patient is looking at the pattern, and then they put electrodes back here on the occipital lobe, and they're measuring how long it takes for the input to go from the screen to the patient's occipital lobe. And they note a latency. So there's a big latency in the left optic nerve. Goes there right away in the right, but there's a latency in the left, and that fits with demyelination, with an injury. So, okay, so lumbar puncture, we already talked about that. So what we find in her workup is that she's got delayed right eye visual evoked potentials, kind of just the exact opposite of what we saw in this case just a moment ago. And that just confirms what we suspect, that she had an old injury to her optic nerve. The CSF, so she gets a lumbar puncture, and the CSF does indeed show elevated oligoclonal bands and an IgG index, so that fits with acute demyelination. And then we image her brain and spinal cord, and we find this in her brain. So sure enough, she has a left temporal lesion here with a big arrow on it. And her spinal cord looks beautiful. So there's nothing in her spinal cord that's a beautiful spinal cord. So yeah, this is a good fit for her symptoms, isn't it? Because she was having dysarthria. Problems in the cerebellum can cause dysarthria, kind of a ataxic dysarthria. It can cause an ipsilateral discoordination. You remember ipsilateral? So she has a lesion in the left, and she was having trouble with dysmetria and rapid alternating movements on the left. And it can certainly cause problems with balance, and she's been having problems with balance and falling to the left. So it's a good fit for her. So I'm not going to go over this too much, but there's different criteria that are used. Most often we use some variant of the McDonald criteria to make this diagnosis, and that requires that you show that there are two instances in time and space, two demyelinating instances in time and space, and we've shown that with her. She had something 5 years ago, she's got something now. 5 years ago it was in her optic nerve, now it's in her left cerebellum. So that's enough to make the diagnosis. Just a reminder, so myelin, what it does is it insulates the axons, and it makes it so that, you know, the nerve impulse, if you have a signal that needs to go from here to there, instead of having to go all the way through the axon, what can happen is it can jump, boom, 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 and so it makes our brain more rapid, more efficient. We can do things more quickly, more efficiently. If we have a lesion in the myelin, you can't make that jump, and if the lesion is bad enough, it might also damage the axon, and so you might not even get a signal go through at all. So you can imagine, of all the millions upon millions of neurons that we have in our central nervous system, if you have enough of these holes, these scars here that are delaying or stopping the conduction, it really can affect the efficiency of your brain. And so, you know, looking at this, it's really not so surprising that things like fatigue are such common complaints in people with MS, as well as more focal kinds of problems. So how do we treat it? So for relapsing and remitting MS, which is the most common variant and probably the one you should focus on the most, it's probably enough for you to recall that there are some other kinds of courses of multiple sclerosis, but by far the most common would be the relapsing remitting. Traditionally, you know, the only real treatments we had for disease-modifying drugs were interferons, and then glatiramer, which is also known as Copaxone. And those were disease-modifying drugs. If you were having an acute demyelinating episode, you treat that with IV steroids. But if you wanted to have a medication that prevents further episodes, you'd put them on interferons or glatiramer. But over the past 10 years or so, you know, there have been a lot of new medications. These drugs, you know, they're still around and we still use them, okay, interferons and glatiramer. But they are kind of a pain in the butt because you have to inject them and there's all kinds of issues with them. So some patients just hated them. And so it's been great that over the past 10 years there's now multiple oral agents, and then there are infusions that patients can go in and get periodically, like Tysabri, natalizumab. And then the idea is that what you do is you put your patient on a disease-modifying drug, send them out, you know, and then re-image them periodically. You know, certainly you want to see them if they have any new symptoms, because that could mean they're having a new event and your medication isn't working effectively. But even if they don't report new symptoms, you want to surveillance image them every so often to make sure that your medication is protecting them. Okay, so you guys can read about this on your own, but transverse myelitis is another demyelinating disease that affects the spinal cord, myelitis, right? Usually 2 segments or more. Can happen in kids. Usually it's adults, but can also happen in kids. And here, the tip-off that there's something going on is often that the presentation that you would expect with a spinal cord lesion, which is kind of a symmetric, bilateral kind of a thing, and then also some bowel and bladder changes. Transverse myelitis is one of those diseases that can follow a viral illness. Usually a viral illness, could be bacterial, but it can also follow immunization. I'll let you read the rest about this. This is also, transverse myelitis, I should say, this is also a condition kind of like optic neuritis, where if somebody gets an episode of transverse myelitis, it could just be transverse myelitis and they'll never have any problems again. Or if you follow the patient later, they could have another episode of something else or another episode of something else, and it could ultimately change your diagnosis. You could decide this patient actually has multiple sclerosis or NMO or something. So NMO, so again, neuromyelitis optica, different pathophysiology than MS, so different, very different in some respects, different in treatment. Likes to involve the optic nerves and the spinal cord. You can see what it looks like here. And then sometimes can affect the brain too, though to a lesser extent than MS. ADEM, so this is kind of a rapid fulminant kind of a thing that affects the brain and the spinal cord. This is another one of those conditions that can follow illnesses, infectious illnesses, and immunizations. Can happen in kids and can be pretty devastating. Okay, this is our next case. I think this is, it says 4, but I think it's number 3. So we've got a young man. 42 is young. He's got no past medical history, but he comes to the clinic because he's been shaking over the past few years, and it's getting worse. So you're kind of trying to figure out what he means by shaking and trying to get the rest of the story. He's kind of a tough historian, so it's really hard to get all the things straight here. But you soon discern that he's been really struggling in life, and he can't keep down a regular job. He could before, but now he just can't keep a regular job. And as you're talking to him, you notice that he's kind of having these continuous movements. He's kind of continuously squirming in his chair and moving everything. He's got these kind of jerking movements. And he's kind of tangential, and he's disinhibited in his conversation. So give me a differential diagnosis, at least 3 things, right? And then come back. So here's what I thought of. Drugs, some other toxin. Wilson's disease, Huntington's disease. So you decide to get some brain imaging on him, and you talk to him about family history, remembering that Huntington's is one of those hereditary diseases. And you check again about any kind of drugs or medications, supplements he might be taking. And then I think imaging is a good place to start, but depending on what you find, you may consider testing him for Wilson's disease or Huntington's disease. Here's what you get. So this is a coronal view. It's an MRI. This is a normal. This is what you would like to see. This is your patient. He's only 42. This looks terrible. So there's a lot of atrophy, right? A lot of frontal atrophy. There's temporal atrophy. I'm guessing that there's atrophy throughout the whole brain. We can only see the frontal and temporal regions really here. His ventricles are huge, right, compared to normal. And that's because he's got ex vacuo hydrocephalus. So as the brain shrinks, the ventricles get bigger. It's not that he has an obstructive hydrocephalus. His ventricles are just bigger because there's less brain. And then look at this here. Here's the caudate nuclei here and here. These are part of his basal ganglia, the caudate nuclei. They're gone in him. They're flat here. So his caudate nuclei have especially atrophied. So what's going on? He has Huntington's disease. So you recall that it can give you these choreatic movements, and it can also give you pretty profound cognitive dysfunction. Usually kind of frontal stuff predominance, frontal abilities like executive functions. You can get psychiatric changes, and it's not uncommon that these patients initially present for the cognitive and the psychiatric stuff, and then the motor stuff is kind of noticed too. So, some patients, the cognitive and behavioral stuff is at the forefront of their presentation. You remember that it's progressive. It's one of those trinucleotide repeat disorders, inherited in an autosomal dominant manner, and there's anticipation. No treatment. We have treatment for symptoms, so we can give him stuff for the chorea. But otherwise, it's supportive care. It's just all supportive care. We don't have anything to reverse the disease. So, okay, that is the end of cases for today. So I will see you back for the next video, and hope all is going well. Bye.